Hi Radha, good evening.
Hi, welcome Baskaran. Good evening everyone. On behalf of Dr. Girdhar Sharma and me, Dr. Patta Radhakrishna, we are the joint admins of this Facebook group called Learning General Surgery, which believes in as a bridge for quality education. And during this lockdown period, we had a good number of lectures, and I welcome Prof.Surendran. Welcome, sir.
Thank you.
Nice
meeting you, Radhakrishnan.
Nice seeing you, sir, after a long time. And Dr.Baskaran is a good friend of mine, and we work together. And he's one of those people who wants to talk, and he's someone who calls a spade a spade. And I thought there can't be a better person than him to run this series in Learning General Surgery on quality education. I hand over to Dr. Baskaran, and he'll introduce the speakers, and he'll go ahead with them.
Thanks, Radha. Good evening to all professionals who have logged in. I can see Prof.Surendran there. I can see Prof.Vijayakumar. I can see Prof.N.Ananthakrishnan who has just joined. And I can see Dr. Balachandar. And Colonel Govind Menon has joined. We are waiting for Dr.Sreekumar Pillai and Ramesh Arthanari to join. Prof.R.Ballal is yet to come.
No, I saw him.
1 minute.
No, he's there. Prof.R.Ballal is there.
Okay, excellent.
Dr. Sumar Rao is his daughter. So the name Sumar Rao is Prof.Ballal. Sir, you switched off your...
No. There's a little problem. It is working now.
Okay. Dr. Girdhar Sharma, welcome, sir. And you have here also, the camera is not on.
Okay, good evening to everyone. A warm welcome to all of you, and thanks to Dr. Patta Radhakrishnan. I have the honor to conduct this panel discussion. We chose this kind of heavily loaded topic. Are we producing surgeons of quality? We are asking whether we are producing surgeons of academic knowledge. We are not asking whether we are producing skilled surgeons. We are not asking whether we are producing research-oriented surgeons. We are asking whether we are producing surgeons of quality. As I presume, and I presume many of you also would think, that when we add this word, surgeon of quality, we believe that it means something like uprightness, integrity, and such qualities which make them stand apart. A surgeon with these qualities would obviously stand apart in any crowd. To discuss this topic, we have a panel of legends, leaders, and passionate teachers. All of them are known for their knowledge, passion for teaching, surgical skills, and much more. I mean, they are leaders in many fields, not just surgery. They are opinion leaders, policy makers. Some of them are advisors to various national bodies, heads of associations. They hold very important high posts in universities and such august bodies. And it is a great privilege on my part to welcome all these great legends and leaders in surgery. I also have a wild card entry panelist. I hereby welcome Lieutenant Colonel Govind Menon. Govind Menon is a plastic surgeon in Command Hospital, Lucknow. Colonel Menon has been chosen because he doesn't know me. I do not know him. He doesn't know any of the panelists. He doesn't know anything about what happens in government medical colleges. He does not know what happens in private medical colleges. He does not know what happens in Tamil Nadu. So I presume he will bring a fresh air, fresh view, and not overwhelmed by all these big shots who are present. Let me introduce the panelists. I welcome Prof.N.Ananthakrishnan, who is generally known as the man from Jipmer. He held the Department of Surgery together in very high esteem, has been HOD for many, many years, and currently is Dean Faculty, Sir Balaji Vidyapeeth, Deemed University in Pondicherry. Sir, welcome. I welcome Prof.C.R.Ballal. Prof.Ballal is known to all surgeons. He used to run the ASA quiz for many, many years. He has been teacher of teachers and he continues to teach. He is generally referred to as a man from Manipur. So I welcome Prof.Ballal in Manipur.
Thank you.
Prof.Surendran is known to all of us. He is currently the Director HVB Surgery and Solid Organ Transplantation in Myatt Hospital, but he is generally known as the man from Stanley, the man who held the Department of Surgical Gastroenterology, who established a Center of Excellence, who got many, many laurels while serving in a government setup. Please welcome to this gathering, sir.
Thank you. Thank you, Dr. Balakrishnan. Thank you, Bhaskar. Thank you very much.
I welcome Professor Vijayakumar. He is an Honorary Vice Chancellor, Yenopaya Deemed University, Mangalore. Like many other people, he is an institute man. He is synonymous with Kidwai. He stayed in Kidwai for more than 30 years, and I've known him for all these years. And I think every stone in Kidwai knows him. He is generally known as the man in white. You don't have to ask, where is Dr. Vijayakumar? You let us just look for a man who wears white and white all the time. 24/7, he wears white and white, and he is in the hospital. And he held the highest appointment of director of the institute for many, many years. He has had multiple appointments. Currently, he is the vice chancellor of the university. Welcome, Professor Vijayakumar.
Thank you very much, Dr. Bhaskar. It's a pleasure and honor to be with us.
Thank you. It's a great pleasure to welcome my old friend, Professor Sreekumar. Professor Sreekumar is a man from Thrissur, who is currently professor and HOD, oncosurgery in Thrissur, Jubilee Mission Medical College. He is also president of Kerala Institute of Oncosurgeons, and he's a man who is known for 3 A's. That is availability, affability, and ability. The 3 markers which are said to be very useful for people in private practice. I'm not sure whether he's in private practice now. Welcome, Professor Sreekumar. Sreekumar Pillai.
Thank you,
Yeah, thank you.
Thank you. Thank you. Hi, sir.
I'm waiting for Dr. Ramesh Arthanari. Dr. Ramesh Arthanari is like the Pandya Kings, the man who reigns Madurai. He is currently the medical director and chief of GI surgery, Meenakshi Mission Hospital and Research Center, Madurai. And he's very, very known for his incisive talk mixed with enormous amount of humor. I mean, you will have to loosen your belt because you will have pain after listening to him half the times. And it's my pleasure to welcome Colonel Govind Menon, about whom I informed earlier. He is currently the plastic and reconstructive surgeon at Command Hospital, Lucknow. Colonel Menon, welcome.
Thank you, sir.
Before we start, I would like to inform the panelists that they are free to move around, of course, since it is not a panel discussion with everybody sitting. If they have other commitments, they can just move for a few minutes, and I hope they can come back. And whenever a question is posed to them, I would request them to keep it within 5 minutes so that we can turn and we can churn many issues. All audience, I would request to put their mics into mute, and if there are any questions, it would be very nice if they can put it in the chat, and we'll ask the panelists to answer your queries. Can I have one small disclaimer? I want to put a disclaimer before we start. Whenever there is a gathering of number of people of particular age, it's common when they discuss about the newer generation on any issue. Let it be sports, let it be cinema, let it be medicine, let it be literature, or even dosa making. Usually you will get conversation like, I don't know what is wrong with the present generation. They don't know. These people are absolutely useless. It's not like the old days. I believe fantastic, great people we had those days. What giants we had. See, for example, Prasanna. See, for example, Dr. So-and-so. Even Komala Vilas dosa, those days is fantastic. Nobody can make dosa like that now. So such comments are common, especially when you want to discuss about the present generation. The usual comment will be all the time on their mobiles. I don't know where this world is going to end. I want to make a statement that none of the panelists or I have any such prejudice. We are going to discuss this issue as mature people. We understand most of the juniors are better than us more often than not. So we have no such prejudice. With this, I think we can proceed with the discussion. As we mentioned earlier, the term we have used is surgeons of quality. So there are many aspects, and I would like the panelists to come on and tell us what they would like their surgeons to be. May I have the honor of asking Professor Ananthakrishnan to start the ball rolling.
Thank you, Dr. Baskaran, and my greetings to my colleagues in the panel, many of whom I have the honor of knowing for several decades. And thank you, sirs, and very nice to be with all of you here. And to relieve Baskaran, I'm going to start by saying I have no intention of raising contentious issues about anything in particular, particularly about any of the students, because students are there of all types in our times, in the later times and before our times. I've seen from Facebook that there's a little bit of disquiet about the topic and skepticism and a little bit of frustration about the topic chosen by some of the comments there. And we will not go into some of those contentious areas because that is not within our area of interest or those that we can influence. Now, to come to my assigned role to define quality, I'm not going to give my own definition of quality because I am but a very small wheel in the system. Let us see how all around the world they define surgeons of quality. Because it's good to know what others do. It's good to know that we in India have also defined what is quality required. Am I audible?
Yeah, very much, sir.
Very much.
Yeah. And therefore, let me start with the Accreditation Council for Graduate Medical Education in the United States, which controls graduate or actually they're postgraduates because they're before post-graduation residency, they're called undergraduates there. Quality is a little more broader than what Baskaran defined because without some of these other attributes, all those he mentioned will not be useful because the patient will not get the best possible service. What does the ACGME say? It says the basic fundamental is, of course, you have knowledge and you have the attitude for proper patient care. You have the skills to help the patient where it counts. You must have good interpersonal skills and you must also have good communication skills, both with the patients and their caregivers in the community and of course with your colleagues. You must be a professional, and the term professionalism encompasses all that Baskaran said about ethics, about honesty, about integrity, about having a caring attitude, about empathy, about having values, and so on and so forth. All of that comes under the broad term of professionalism. They have two more attributes that the graduate must be able to function within the confines of the system, that he should not always be challenging the system. So that they go by the name of system-based practice. And a very important attribute, they say, somebody who constantly improves his knowledge, practice-based learning and improvement. Around the world, these are the same qualities. They call it by different names, but essentially the same. Now let's see, after so many years, the Government of India and the Medical Council of India have defined the qualities and called it the qualities of an Indian medical graduate. They say he should be a good clinician, he should be a good communicator. Pardon me if I am saying he, it goes without saying that it also includes she. He should be a good professional, he should be a lifelong learner, and he should be capable of being a leader and member of the healthcare team worker. What is not mentioned, very unfortunately, in the IMG definition is any mention of awareness of economics of medical care. That we have to provide cost acceptable, cost effective, and appropriate treatment depending on the patient. One size does not fit all when it comes to treatment. It does not mention that a good quality surgeon should know the limitations and therefore be recognize situations where he or cannot intervene effectively and not be ashamed to refer it to a proper center where proper treatment can be done. And the last thing that I'm going to say is the doubling time of medical knowledge in the 1950 was 50 years. So you could have passed, you could have completed your service without knowledge changing. In 2020, the doubling time of knowledge is 73 days. And therefore, he has to be one who has to learn to evaluate evidence so that he can apply the current evidence to the benefit of his patients, which is another quality that we often don't teach our postgraduates. And if you put all this together, by whatever name you call, it fits my definition of a quality surgeon. Thank you.
Thank you, sir. May I now request Professor Surendran, what you would like to say about this?
Thank you, Dr. Baskaran and Dr. Radhakrishnan for this opportunity. It has been a wonderful opportunity, and I thought it's my privilege to be with this superb panel. And I entirely agree with Professor Ananthakrishnan. He has been a man who has been doing a lot of work in health education, medical education. But what I feel that, whatever the US or Indian Medical Association or the Medical Council says, I think the panel is called to express their personal view, because all of us, we have some idea about what other people say, but I strongly feel that yes, you need to have the skill, and you need to have communication, and you also need to have some idea for social commitment, like the commitment to the society. And what is more important is the ethicality and morality. I think we have to underline, because that is where I still feel that our forefathers, our teachers were much, much, much better in this later aspect, though not in the kind of the knowledge what we are supposed to possess now. So they really definitely they score over others, ours rather at present, because ethically, morally, and social commitment is much higher those days when compared to. So I thought we have to add this along with whatever Professor Ananthakrishnan has said. Thank you.
Thank you, sir. So Professor Surendran insists that people should have high morality, of course, as Professor Ananthakrishnan also said, but he insists that there should be some amount of commitment to the society. And he feels that probably as a generation, we are not doing as well as the previous generation. So I'm not going to extrapolate it for the next generation, but it may be accordingly felt. Nevertheless, let me ask Professor Vijayakumar for his opinion on this issue.
Good evening, everybody. Nice to see all of you. I'm happy to see everybody there, whom I know, everybody except, as you said, Govind. I know all of them personally. Thanks for allowing me to see, including Prof.R.Ballal and Sreekumar Pillai. Sreekumar Pillai I met long, long ago. Thank you for this opportunity. So I was just thinking it all comes to only one, according to me, competence. You may be wondering what competence I'm talking about. I'm not just talking about professional competence, which is based and knowledge-based alone. I'm talking about the emotional competence, the ethical competence, and the social competence. If you include all this, apart from the technical skill, which we probably are expected to learn, which most of us learn over a period of time, both the science and art of surgery, which what we are built to become, and we all become one like that. But to be a good surgeon, not only the hands should work, but the mind and heart probably should play a more important role. By mind, I mean not knowledge. By hand, of course, you know it's a technical skill. The third most competent one is probably the most important one I will be thinking of. That is the compassion, human and humanness. Many people don't know the difference between being a human and a humane. I'm talking about being humane. And all this will revolve around what Professor Surendran already told, that it's what I am talking about is ethical competency. If you have an ethical competency and moral competency, obviously you are going to not only talk about the social commitment and the patient in front of you and their relatives and their family, you start thinking beyond the patient. As we always say, when you talk about treatment, you see beyond tumor, like that you see beyond patient. And the most important thing I would say, what I call it as, many of them will agree also, the professional honesty. There are enough and more to talk about professional honesty. By that I mean not the technical skill, but much more beyond that. The professional honesty is to accept your limitations, for example, and if a better person is there, to send them there to that. I just gave some examples. And another professional honesty is when there is an alternate method, particularly I'm talking oncology, when radiotherapy or chemoradiotherapy is better, I should be able to accept and send it to someone. And that's what I mean by professional honesty. So with all together, only I feel quality comes out, not just a professional technical competence alone. This is what I would say as quality. Hope. As I'm going with what Dr. Surendran said, going by any association definitions. In fact, I saw for this sake Royal College what it talks about the good traits, etc. But this what I'm talking is my heart out.
Thank you. As an onco surgeon, you have spoken. Now let me ask the young man in this crowd, Colonel Menon, what do you think of surgeon of quality?
Well, for starters, I immensely thank you for being allowed to come in this panel discussion. It is a matter of great honor for me. Thank you so much. So, from what has already been said, almost everything seems to have been covered, and it is very difficult for me to say something new. But then, as I look at it, if I had to say something about attributes of a good surgeon, there are certain things which are expected out of a resident after once he becomes a surgeon. So the qualities of the surgeon, which I believe are already expected when he joins a surgical training program, would probably include things like sincerity, a commitment, dedication, absolute honesty, and having an empathetic nature, apart from being obviously knowledgeable about the subject he is likely to learn. But then there are certain other things that I feel probably in today's training requires a little more reiteration. And some of those qualities which I feel that probably may exist or may come freely to some students or some young surgeons may not necessarily come for others. So a little bit of reiteration that may help the younger surgeons to become better teachers and better doctors would include something like owning up, courage of conviction, having a high moral stand, being open-minded. Now, being open-minded, I would say not only to ideas and changes, but also probably to suggestions and criticism. I think so. I have had the privilege and honor of having been taught by teachers who were very open-minded, and that changed my entire perspective of surgical training and surgical education. Something that, again, that may not come naturally to all people, I would say, is something what I would qualify as leadership qualities. Not everybody is a born leader. So I think so as a teacher, as mentors, and as and people who follow a tutelage, I think so leadership qualities need to be instilled in young surgeons. And as of today, I think so one of the things that is expected most, and is probably a requirement more than anything else, it is a necessity, is having soft skills, probably having good communication skills. So it was what I would like to say is that this is what I would like to say would attribute a good surgeon.
Thank you. So all the panelists so far have said a surgeon should have lots of good qualities like compassion, leadership skills, thinking, being humane, many other things. Whereas somebody has asked the questions, all you people are discussing is all theoretical and subjective. It's a very utopian. Is there any objective way to assess this is what a person should have?
Yeah. Can I come in here, Baskaran?
Yes, please.
Yeah. Every one of these parameters which are mentioned by all of us, and if you put them all together, they come under the category of being a professional, and the professional within quotes, everybody understand what it means. These are not utopian, because those of us who are actually in the medical education field are made aware that there are methods of making students aware and learn these things, and there are methods of evaluating them to see whether they have reached this level of competency required. And I'm sorry to introduce some technical terms here. There is an attribute called an entrustable professional activity, which defines competencies of surgeons. And it defines levels of attainment at various stages of training. And every one of all the attributes mentioned has got a rubric to define what it means, and a suggested teaching learning method, and a method of evaluating it to find out whether any particular student has reached that, or if they have not reached that, what additional inputs we should give in order to enable them to reach that level. If we don't do it, it is because we as teachers don't pay attention to some of these soft skill issues, focusing largely on the patient care and knowledge aspect. And the students cannot be blamed at all for not having some of these attributes when they qualify. But none of them are subjective, none of them are utopian, all of them are well defined, and there are methods of enabling these attributes in students and enabling and making sure that they have these attributes.
Thank you, sir. Essentially, a majority of these qualities which you have mentioned and which others have mentioned are attributes required of a good doctor, per se. Now, somebody is asking, are there any special qualities like motor skills or something which are required to be a good surgeon? And may I ask Professor Sreekumar Pillai to come on and give his views on the need for additional qualities to distinguish a surgeon from the rest. Dr. Sreekumar Pillai is off. May I ask Professor Ballal to take on this, sir?
First of all, as per my good friend Ananthakrishna's suggestion, I should not be in the panel at all, because 73 days. I retired from teaching 5 years ago, practiced much earlier. So you may consider me one of those species about to get extinct. But thank you very much. To my mind, one of the qualities which defines a surgeon much more than other specialty is resilience. To be there when things go wrong, to keep a calm mind, face these problems, which sometimes occur very frequently, still be able to help the patient maximum extent. This resilience is a character, I think, which is needed for surgeons much more than other specialties. Of course, to begin with, the very fact we're discussing the problem means the type of surgeons we're producing are not of good quality. Otherwise, all this discussion would not have been necessary at all. That's the first presumption. I think most of the teachers, my good friend, Dr. Vijay, he holds a university vice chancellor position. Because the product is bad, we are all here. Am I right, Dr. Bhaskar?
No, sir. No, it's a very open question. The question is, are we producing people? I'm not saying, why are we not producing? I'm asking, are we producing? If
you're producing good,
we are producing adequately, then I'm happy. All of us are happy. If we think we are not producing adequately, then what mechanism we should institute, if possible, to set it right?
I'm looking from a different angle.
The previous one, sir.
Very fact that idea came to you means there must be something wrong with Rome. If everything was proper with Rome, all of us would have been sitting and having a cup of coffee rather than talking for the next 1.5 hours. I fully agree with Dr. Ananthakrishnan. Has done a very detailed study. Vijayakumar also is holding a very high post. So I agree with you because so often seminars and discussions in this country end up with a lunch, and after lunch, everything is forgotten. There's a very valid point, which Dr. Ananthakrishnan said, that if you apply your mind, most of these can be taught to our own students. I think rightly said, we have to take part of the blame as teachers. There's so much of focus on technical skill, first of all, because student, Dr. Menon mentioned this point earlier, I think. Students, when they join in the Facebook discussion, you see so many times, should I join college Y, college Z? And the answer is college Z has more cutting chances, therefore go to college Z, as if cutting is the only thing that matters. That impression should be taken out. When they, first of all, with the student has the attitude to become a surgeon, because a lot of what has been described is an ideal situation. All of us are aware that admissions in this country are not completely under the control of there are so many extraneous factors. So there may be a group which you have come to the ideal status over the period of 3 years. But to my mind, resilience is one thing that is, of course, it includes all the characters, but we have to be resilient to be a good surgeon.
Thank you, sir. In fact, yeah, Professor Vijayakumar has a point. Yes, please.
Somebody has said whether it's utopian. I just want to say that I want to quote something that everybody will accept. Idealism and perfectionism is like playing a losing game. But unless you aim at perfection, you will not be anywhere near it. I repeat, unless you aim at perfection, you will nowhere be near it. So, aiming at, even if you think it is ideal and utopian, unless you aim, where are we? We don't even have a template. Unless we have a template and have a goal to work for it, we'll nowhere near it. We reach or not is a different story. As Professor Ananthakrishnan very rightly said, there are enough modules are there how to do it. As we spoke about entrustable professional activities, and also people should know what is competency, and everything is well defined. It's a specific area of performance that can be described and measured, and for that milestones are also placed. Only problem is many of us know it, but we are not willing to accept and implement it. Probably we think they're all lesser modules to talk rather than professional skill-based learning. Because I also have to accept one thing, all of us here will accept. During our time, the number of cases, number of exposures we had clinically were much, much more. Reason be anything. So I was ready to work for 24 hours and I was able to do that also, meaning technical skill also was parallelly going up. Probably the present generation, as I am seeing, even now I am teaching, the number of cases which they are seeing as drastically has come down. So the skill-based learning, which they are all worried is not happening, maybe they are frustrated with that. But what we have to tell them is the art of surgery, which they are talking about, is a continuous learning, and that is the curse of our course. We have to keep on learning and we continue to learn. If that we say, then they will mellow down a bit and then not only concentrate on the science of surgery, but other aspects which we are trying to talk about it. It is we, as he said it, teachers who have to instill all these competencies into them rather than expecting them to learn. Because once upon a time, I still remember, all of us here will have been told, surgery was never taught, it is learned. But I think everything has to be taught is what now I feel after going through everything. Not that it is self-taught, but it has to be taught. It is not learned on its own. Sometimes many people are blessed with seeing and able to duplicate the same thing or imitate, but some places where you will have to teach them every bit of it so that they become better than what it is. Even if I always say, you get mud, then only you can make a pot out of it. You cannot get a bad pot and try to however much you try to do, you cannot. So best thing is for a good teacher is to have a good mud. Then only you can make a pot out of it.
Thank you. Now, before I move to Professor Ballal, you wanted good mud. Now, how do you get good mud? From what I hear from a whole lot of people is that the current lot of people who enter surgery, very few are actually interested in surgery. Majority take up surgery because they didn't get anything which they wanted. So instead of sitting at home or doing some diploma, they would rather come and do surgery. Now, when you have a material like this, how are you going to mold them into good surgeons? Before I go, I would like to remind you of the presence of Professor Girijadatta Sharma. He is of the view there is never a fault with the residents, it's always a fault with the faculty. May I ask Professor Ballal to kindly address this issue, sir?
Fully agree with, because I have seen students, who had got a seat in medicine last minute. They somebody mentioned in my college, I am the head of surgery. This boy jumped into surgery, and he came with absolutely no intention of becoming a surgeon. At the end of 3 years, I was able to convert him. I think it's the amount of effort, extra effort. My point was, instead of beating around the bush, let us take one point at a time, discuss thoroughly, then move to the next point. So we will now talk about admission.
Okay.
Can we start with admission? I'm sorry, I would like to start much earlier.
Okay, we'll come to that later, sir. We'll first go with this.
According to me, the limited number of postgraduates at your disposal, with the type of case material we had, I was able to convert many of these students who came with not much of interest in surgery and became quite, by the time they finished 3 years of, at least they were quite safe and good surgeons, I would say. It is possible. We have to put extra effort. Focus on them, find out their weaknesses. If you knowledge, make them read more. Technical skill, hold their hand right from making the skin incision. That was my habit. I always used to go with my PG for the first hydrocele, first hernia, because those days we were using in Mangalore. I shouldn't say that. Mangalore is we have a very big fishing industry. So we used to get a lot of those nylons, which are meant for fishing industry. That was mounted on a needle. We didn't have eyeless needle those days. And my worry was every time they put the needle, whether it will enter the femoral vein. And surely one, at least every year, would enter the femoral vein. I had to teach him how to tackle that. So it's possible, provided the teacher puts in extra effort.
Thank you. Sir, we'll come to the hands-on skills a little later.
Okay.
As a resident or as a junior surgeon, a person thinks he's a surgeon only when he does a number of operations. His aim is to do so many this procedure, so many that procedure, so many this procedure. But many times it might not really be the quality that is expected of him. So there is a mismatch between what the society wants from a surgeon and what the surgeon thinks he should have. So the number of surgeries or the hand skill is what he thinks is the most important. Now, if you list the main attributes a good surgeon should have, let's ask the panelists, where will this surgical skill come in? Let's start with Professor Surendran. Sir.
This has been already discussed in our in some of our specialty meetings, the gastroenterology conferences. I think Professor Ananthakrishnan will be the better person to explain on this. And we had, minimum number of certain surgeries a student must have done to say that he is competent enough to have the, the surgical skill or whatever you call it as. And I just wanted to tell you asked us about what is the difference the surgeon has when compared to other specialties. I thought the resilience Professor Ballal said is excellent. And along with that, it is something like, the surgeon must have that decision making, an absolute, something like a war footing. So during surgery, if something goes wrong, you should be able to manage it. Otherwise, it's going to be a now or never emergency. That's one that clearly distinguishes a surgeon from other fields where they can go refer Google, refer some books, and then come back and tell that, no, I've given wrong medicine, change this, that or not. But the surgeon doesn't have the time. So that's a very good quality. I thought every surgeon should imbibe. So naturally, for him to imbibe that quality, he should have a wide knowledge. It used to be said, when we were a postgraduate, that for a surgeon, you don't need theoretical background. No, it is wrong. They said the physician should have more of theoretical background and knowledge. It is not so. The surgeon should be an operating physician. So I suppose the panel will agree with that. So that's what I should make a decision. I mean, this is this defines a surgeon. And then, Dr. Vijayakumar said, yes, it's correct. But I wouldn't say totally that these days the students are bad. At least about 15-20% students are far better than what we were. And they have, approach to, they have accessibility to all those online, the YouTubes and Google and all those things. They have the knowledge at their fingertips. But another 50-20%, and whatever you do, I think you cannot bring them up. You cannot make them a good surgeon. We are only worried about the rest, the in-between. If the teachers are good, if they are guided well, you bring them up to as a good surgeon. If you don't, they go to the other end. Unfortunately, that's where they are going these days. I think that's why this discussion.
Thank you, sir. Professor Sreekumar Pillai is back. We were discussing the qualities a surgeon needs, and many youngsters believe most important quality they need to have is the surgical skill, hands-on training. So, if you are asked the rate from 1 to 10, where will you place hands-on skill? Dr. Sreekumar Pillai. There's some problem with that communication?
I think so. I don't think he's able to hear this.
Okay.
Can I say something, Dr. Baskaran?
Yes, please.
Yeah. About the role of operative skills, I agree that somehow adds to the glamour and is probably the attribute which is most desired. But by itself, it cannot make a quality surgeon. Why? Because sometimes the decision not to operate is even more difficult to make than to operate. And we don't teach them very often how to decide when not to operate. The ability to bring them to an appropriate level of fitness before we do surgical intervention is as important as the manipulative procedure that we do on the tape. The ability to manage them pre-operatively and post-operatively is perhaps as important or even more important than the short period that the patient spends on the operating table. The ability to be aware of alternatives and not do something merely because you're familiar with that when an alternative may give a better result, may not be in your hands, but in other hands, is also an important aspect of training of a surgeon. That's where I started with by saying to be aware of your limitations and to refer at the proper time to the proper place is even more important than being able to do a procedure. The other day in learning general surgery, we had a discussion of a patient who had a 12-hour cholecystectomy. And obviously, things did not go well and ended up with a lot of complications and avoidable complications, some of them. Perhaps not the correct time to intervene and so on and so forth. So all these, somehow, the glamour of cutting, as Professor Vijayakumar or Dr.Ballal said, I don't remember which one, overwhelms all other attributes, which to my mind are even more important. And I tell my students, the manipulative skills of chimpanzees are much more than human beings. If you can teach them, they'll probably do a better operative procedure than any human can. But that is not what goes to make a surgeon.
Thank you, sir. It's very interesting that a long time ago there was a publication in, I think, in American Journal of Surgery, which asked patients the qualities they expect from their surgeons. So it would be surprising if I tell you the surgical skill was rated very low. It was 9 and below. And the first
wise patients.
Pardon me?
Wise patients, I said.
Yes, sir. Correct.
Baskaran,
the first quality they wanted.
Dr.Ramesh Arthanari has joined.
Oh, excellent.
The surgical skill is known
Arthanari.
The surgical skill is known only to the anesthetist and the sister assisting. Nobody else knows your surgical skill. Patient comes out vertical, relatives are happy. The problem is only when the patient comes by horizontal. So how good you are on the operation table, I happen to have my own cousin as anesthetist. And he was training many of the young gynecologists. He had seen so many hysterectomies being performed. He was training them actually. So skill is something which is noticed within the OT. As far as the relatives are concerned, I think the way you approach, the way you talk to them, all those things matter much more than they are not aware of your skills. That's a limitation.
The people describe being human, as Professor Vijayakumar mentioned, is the #1 quality they expect from the doctors, especially from the surgeons. Okay, now that some of these issues we have been discussing, it's very interesting to know that the Bureau of Labor, America, stipulates that the surgeon should preferably have good physical health, stamina, and because he is expected to lift, turn, and move patients. And so a surgeon probably will have to have the stamina like a truck driver. He should have the capability of a carpenter, plumber, a good teacher. So he will have to wear a whole lot of hats.
Add on a tailor also. A lot of suturing takes place. Add on a tailor in addition.
I don't think that a surgeon needs to lift weights and all that. If in the US, in many hospitals, what they actually do is that the patient is transferred onto a stretcher in the ward by the ward nurses, orderlies. The stretcher top goes onto the OT table as part of the OT table. So then the same stretcher top comes off the OT table and goes to leave the patient back. Why not? So the table, they have 4 or 5 tables, so they keep changing the patients that way. So I think in India, say in United States, obviously the amount of manpower is limited because they have very strict rules on Minimum Wages Act and what all facilities. So they tend to keep these manpower to a lesser extent. But in India, really, that's not a problem. We have enough theater boys and all, young fellows, strong fellows who lift these patients. So I don't think I've gone to lift a patient in the last 10, 15 years.
It's only symbolic. They say that you need to wear so many hats. That's it. So it's not that you have to manage patient.
I think they get trained to lift patients when they're PG students. Yes. That time they're forced to lift the patient.
I'm sorry. I'm sorry I joined this late in the discussion. But to me, the main deficiency in the Indian system at the moment, there are 2 main areas which I am very upset with, and I think that it needs somewhere somebody has to put their foot down. The first is this business of saying that we have a surgeon trained in 3 years. All of us know that 3 years is not sufficient for a surgeon to be trained. In 3 years, you get to know the basics. You want to bring him out as a consultant capable of doing most major work. You need at least 6 years or 5 years as in USA sometimes, but at least 5 to 6 years I think you need. It should be integrated. Now the thing is that some people do the senior residency, but many of them when they get their MS, they think they are consultants and they want to go out and start a practice. And I think that is where there is a big lacuna because just by 3 years, they have not, they may have done some surgery and all, but everything is under guidance. It's only when you are at the senior registrar level that you independently do and you guide juniors and you become more mature. I think my own thing is that the 3 years of senior residency after the general surgery degree was where I really was able to become a fully trained surgeon. And the second thing is that in the last 3-4 years, without putting any brain into it, they have increased the number of seats many times. No, you do it in medicine, you do it in cardiology, it doesn't matter because 10 people can also auscultate the same heart or the same lung. But you take the same number of patients, same amount of operating time, and suddenly you take it from 2 students a year to 10 or 15 students a year. It doesn't make sense. I mean, Tata Memorial, for example, used to take 2 MCH candidates a year. And now they take 16 or 18 per year. So what people forget is that at the end of 3 years, all the time you have 48 candidates. And your work has not increased 8 times. So I think this is the biggest deficiency that needs to be addressed.
Can I, Ramesh?
So before 1 minute,
This is,
Vijayakumar will say we are a town of Mangalore, 6 lakhs people, and we have 9 medical schools, and all of them have postgraduates. So Vijayakumar is the right person to comment on this, because 6 lakh population. When we started, we are the only medicology PG course. Now every medicologist, he is a vice chancellor of one of those universities. He is the ideal person to comment on this aspect.
Sir, there is no second opinion on what Dr. Ramesh Arthanari spoke now about, as I also touched upon it, but I repeat. The FCA said 1:1, which you all of us sitting here know as the teacher-student ratio for postgraduate. For reasons unknown to me, in fact, I went to the extent I can openly tell, fight health minister of Delhi for having done that. I tell what answer he gave also at that time. 1:1 became 1:2. Now it has become 1:3. Without changing any aspects of OPD number, IP number, OT numbers. Nothing has changed except they said for 1 unit, 1 professor, you can have 3. And a maximum 1 unit can have is 4. That means what I was teaching only 1 student at a time, now I have to teach 4. As Arthanari jokingly said it, I understand teaching. But when it comes to patient-related activities, including diagnostic, decision-making, particularly surgery, same number of hours, same number of OT tables, but they've increased. And I have to tell you this, sir. I fought with that time Health Minister of Government of India, and he said, frankly, it was his brainchild. I said, what do you mean by brainchild? Then he said, that is the only way you specialists will be flushed out of the city. I'm exactly quoting his word. This is the only way you will be flushed out of the city. By making the numbers, you will go. Otherwise, you are dictating. We don't have enough numbers going to the second and third tier cities and forget about districts and villages. This is the only way. That is why it was done. And I am telling you proudly, it is my brainchild, he said. It is very unfortunate because
See,
without even thinking that quality people will not be able to come out, only quantum and that overnight decision was made without consulting any of the professionals or the academicians. It's unfortunate, but they have done it. But we have to probably put up with that.
I think so. What Vijayakumar says is absolutely right. Those days, the heads of the department will ask for number of seats. They'll say they'll restrict about 2 seats per year for a specialty, wherein maybe in 3 years' time we'll have only 6 people to train with whatever the infrastructure what we have. But these days, they thrust upon the heads of the department or the heads of the institution or even the director of medical education. They don't have a say. It is being thrust upon them. So long as I was the HOD in Stanley, though they say that take 6 seats per year, and I said no, only 6 people for 3 years. Only 6 people can be trained in a department maximum. But they used to say that Dr.Surendran, he doesn't want to have competition. I mean, this is exactly what they were telling. Now they have 7 seats per year. So at the end of 3 years, you have 28 people to train. Do we have adequate infrastructure? Do we have adequate patient flow? I mean, do we have a control? No, we don't. Exactly. I think we
at least on the national board, what the national board does is that we have 2 GI surgery seats. They wrote to us and said, if we want, we can take 4. They left it to us. And I said, I don't want, I want only 2. So they should allow the department heads to decide how many they can train and give adequate hands-on training. Because for me, 2 DNB GI surgery per year means 6. And this is what I think in my workload I can train well. If they give me 4 per year, which means they make it 12, I think that I can't give them adequate practical training.
Okay.
Leave alone surgeon, Ramesh. If you take MBBS, the government of India says that we need to have for every 1,000 population, we should have 1 doctor. Right. So they are increasing seats. They say by 2022, we need to add about 500 medical colleges, something like that.
No, the problem is that it is very lopsided. Kerala, Tamil Nadu are already 1:700 people or 500 people. We
No, there
exceed
is
world
a,
standard.
Ramesh, there is a very good article in the Times of India, I think in the November issue, where they say in Tamil Nadu, for every 1,000 population, we have 4 doctors.
Yeah, so we have got too many doctors.
We have too many doctors. We don't know the government policy. What will happen? Okay, all right. If 1 doctor for every 1,000 population, if we reach, after that, what will they do? Will they close all those medical colleges?
Correct.
We have already reached. We have got 4. Now we are already beyond that. In Tamil Nadu, it's about 1 per 800 population, and Kerala it's around 1 per 500 population. But Tamil Nadu has announced that this year they want to add 7 new medical colleges.
Right.
So that is politics.
Correct.
I think that
I think it's all politics.
I think we are moving away from the
average.
We are
We
moving
are
away.
looking at national average. And states like UP, MP have very few medical colleges. The total number of seats.
So then they should start it there. They should not start it in Tamil Nadu, Kerala, Karnataka, which are excess.
There are so many vested interests playing a role. Okay, now
Yeah. And if we object, they say you have become doctors, you don't want competition. Like Surendran said, that is what they keep telling us. That if we object, it is because we don't want competition. But then they should understand that there is no work for these people. The government can't give them jobs. There is not enough work in private hospitals to sustain such a heavy pay. And everybody now wants to become an MS or an MD or an MCH or a DM, and we don't know where this is going to stop, because virtually nobody is happy with an MBBS degree, though they can make a lot of money. The people I know who have only MBBS and they have settled down in small, very small taluk headquarters and all, there they actually make more money because it's all in cash, no income tax. They make more money than many of the bigger doctors in the cities. So it is not that they can't, but they don't want to. The children don't want to live in small towns. They want to come to big towns for better education, better facilities.
Can I come in, Dr. Baskaran?
we are just going out of the topic.
Yeah, because there's a feedback from chat from a lot of people who say that we are not sticking to the subject.
Correct.
I think we need to come back to the subject.
No, but then the subject is competency of how to have a surgeon, competent surgeon trained.
Yeah,
Now that is what I'm bringing. This is the reason why the competency, I think, is now become very low. The period and the number
Ramesh.
of PGs.
Good point, Ramesh. But I think we have to leave it there and get on with the
Ramesh,
thing.
all of us are aware of the problem. Let us discuss the solutions rather than.
Yeah, right.
Correct.
Very well.
We all know.
I'll just raise one question raised by one member of the audience. Respected panelists and seniors, says Dr. Mohsina, in countries like UK, US, there are set guidelines put forward in the description of the course regarding what each resident will see, do, learn. And similarly, every aspect of the training, knowledge, as well as skills gets evaluated with a feedback to students. What are the reasons that are hindering incorporation of these into our training, in spite of realization that soft skills and technical skills, which all of us have said that are equally important? And the answer, in very briefly, Dr. Mohsina, is lack of motivation from the interest in the regulators, lack of interest in the teachers, because to do this takes a lot more work and none of them want to do that. It's much easier to stick to the convention and then avoid areas where we have to work a little more in order to produce the desired results. And I have been struggling with the surgical gastroenterology group. Dr.Surendran knows, and perhaps Ramesh also knows, to make these competencies written and have assessment skills and enable measurement across India to ensure competency. And for the last 1 year, I have not succeeded in convincing all members of the group. So that is where we stand when it comes to these soft skills.
Can I make a very honest statement about this? Because Dr. Ananthakrishnan has said it, but in his usual little diplomatic style, he was very diplomatic about the whole thing. The fact is that most of the hospitals, the senior most professor, because as I said, that in most of these hospitals, they have started 7, 8 units. In Ahmedabad Medical College, I believe they have 29 or 30 units in general surgery. So what happens is that a unit will get a table once in a week or 2 tables a week. unless it's a very big operating theaters, number of theaters are more, they get very few tables, 2-3 tables. And they have, as we have said, about 15-20 postgraduates wandering around. But the professor doesn't want anybody to do, and only he will do. So there is very little chance that others will get. This is the biggest problem I have seen in my career, that this, professors and the next level consultants want to keep doing the surgery, and they are reluctant to allow juniors to do the surgery. This is the reason why I think in the surgical field that there's a resistance for, because once you have these guidelines, you have to show so many cases were done, they were done and assisted by this PG, done by that, and most of them can't come up to those figures, then they will get into trouble. So they don't want to start with.
Ramesh, I don't think we should blame the teachers, because there are institutions where teachers are very liberal, lot of chances are given, but the problem is the number of patients that come. Teachers want to give as many chances as possible to the postgraduate. They don't mind assisting, but as Dr. Vijayakumar put it, the input is so low, get distributed, so the number of chances get. Before that,
That's what I'm saying. The total number of chances become less. So obviously, even the professor would like to do 1 or 2 cases, and then he does 1 or 2 cases, and everything comes down from there.
I don't think it's a universal fact.
I think it's a big factor from what I have seen.
Yeah, I agree. Shall we get into this little later? Now let's talk about a few other things. We were discussing the qualities which a surgeon is required to have to make him a complete or good surgeon. See, as somebody mentioned, Vijayakumar mentioned, that these factors could be those of hands, those of the head, and those of the heart. So let's start from the top. Somebody mentioned, I think it's Colonel Menon, who said the leadership qualities. So let's start with how can we impart those qualities which are of mind, like leadership, uprightness, integrity, ethics and all. I mean, this is not part of the curriculum. I don't think it is there in the MCA curriculum. So it is the requirement for the surgeons to learn. So how are we going to incorporate this kind of training for surgeons? Yeah.
No, the most important thing to incorporate this sort of a thing, ethics, honesty, how to do, is for the surgeon to be an example. So for himself, a role model. So if every day he sees a patient, the way he talks, if your surgeon is doing a case because he'll get money and not because the operation is indicated, that is what the student will learn. So I think I don't think these things can be taught. These they have to observe and learn. I think this, and we have to guide them by doing things the right way. And unfortunately, I think that is also lacking in whether we like it or not in many people. And so,
Ramesh, you think in a society so corrupt, only surgeons should become angels, is it? Is it possible? You see a corruption all around in such a massive scale, and people are paid 1 crore, 1.5 crores to get in. Their motives will be obviously different. So you got to look down at reality.
I agree with you. So we can only show them this is the right way. We can't, and I mean, they may see it, and when they go out, they'll do exactly as you say. Because I have had candidates who come for interview to work in the department or to join the department as a trainee or as an observer, and the father comes or the father-in-law comes with the trainer, and then I've had 2 people when I've told them that they'll be given this much of a salary. He says, "What is this? I have paid 1.5 crores to train him in this, and now you're saying you'll give this much salary." I said, "Look, why are you coming here to learn? You've obviously not learned. You want to come here and be a learner. I can't give you more salary than this. Even our consultants only get this much." Then he is very disappointed. Why do you people keep the earn so low? Why do doctors earn so low? We've spent so much money. And I told him frankly, I said, "Did you ask any doctor how much he makes before you spent the money? You didn't. You just assumed that seeing Rangabhashyam or seeing Gopinath or Girinath in Chennai who make crores, you think that everybody will make that much money."
I think Ramesh,
Ramesh, only they are visible.
we should not mention names if you don't
Yeah,
mind.
I'm saying,
Right?
I am mentioning it very correctly. These are very well-known people.
Please,
Everybody
please
can't
don't.
make money like that.
No.
This
I think we are again moving away
panel
from
will
the
not
topic.
mention
We are talking.
names. Please don't
We are
mention names.
digressing from what we are talking.
Exactly.
I
Let's,
think Dr. Baskaran.
Menon wanted to make a point. Yeah, Menon, please.
Yes, sir. My point was very simply, how do we inculcate or instill such attributes in young surgeons is by what we call, I'm sure you are aware, sir, by the army, by leading by example. What I'm trying to say is that unless you fill in the shoes and show them what is to be done, I think so it will not take place. And qualities like decision making, being a leader, taking the whole team together, keeping them in confidence, sometimes even exposing your weaknesses both to the patient and to your team may actually motivate a surgeon in the making in this process. I just wanted to make that point. It is solely going to be by leading by example, and there is no other way.
Exactly. That's the mentorship. You know, the mentorship is lacking.
Yes.
So I think we need to train the trainers. That is not there. Most of the medical teachers these days, they get into medicine not because of passion. They wanted to get into a medical college which is situated in a city or in a bigger place. And they're not really interested in teaching. If they're interested in teaching, they will stay back. They will have a big group of students will adore them. They will bring up good character in the students. So that I think we are lacking. I don't know what the panelists feel. Definitely there is a deficit of a good teacher.
Agreed.
Yeah.
Baskaran,
Yeah.
Bhaskaran, I will tell you. One day I was at a party, and there were half a dozen other surgeons from my age group and younger. All were high on alcohol, and you know that alcohol loosens the tongue. So one of these surgeons in that group was very well known for teaching youngsters, for giving them chances, and he was very liked by all the students. But all the other surgeons who were working there, they were very angry with him in that night when this topic was suddenly started, and they said, "Why are you training them? By training them, you are making them our competitors." This is what other surgeons. These are all teachers, all professors, assistant professors, and they were scolding this fellow. So this is there at the back of the mind of many of the people who work in the medical colleges, and that is one of the reasons why they don't want to allow the PGs to learn. I am not saying that all of you any of you are like that, but that this, it is there, this undercurrent is there.
Yeah.
And what Surendran said,
Your point is well taken. If a person is underconfident, he cannot face competition. If a person is competent and he is capable of dealing with everybody, it's fine. It's an open market. If you are sure of your competence, you don't mind any competition. If you are not sure of your competence, you obviously is very worried about competition. That is very good. See, we were talking about mentoring. It is well known that the children do not behave as you tell them. They behave exactly as you behave. All of you would have seen when you go in the morning, the maximum traffic violation is done by a father who carries the children to school. Understandably, the children do not know there is something called traffic rules. So they, like you said, they observe and they do that. Whatever you may say, they don't follow. Professor Vijayakumar has a point. Yes, please.
Yeah. See, we are repeatedly talking about both. Now we are coming to student as well as teachers with the quality. In fact, we have slipped into the teachers' quality also. So again, it means two things. One, for me, I like a quote. Some are born great, some are made great, and some greatness is thrusted upon. So some are born surgeons, some are made surgeons, on some surgery is thrusted upon. That's all it is happening today because of the sheer numbers. Only top people would have got something becoming a teacher. Earlier, a surgical teacher means he was adored. Today, I have to accept this. People may or may not like it. For the want of going for somewhere, he is just going on to a medical college to become a teacher, not out of passion for teaching.
Exactly.
For the sake of security, he will get it, and then he will go. And if he is not a well-trained surgeon or not a confident surgeon, unfortunately, he becomes a bad teacher. And so whatever now Dr. Ramesh Arthanari spoke about not giving chance, everything will come because not a passionate teacher. So what do we do for that? We have to see. Two things we can do for that. Number one is make everybody competent by increasing the number of years, if not after the degree, at least like an internship after MBBS. I feel there should be called by any name, apprenticeship should be there after the MS. That will make at least some amount of skill-based training at that level. At least he will be industry ready. He is not industry ready today, so he doesn't want to go there. He wants to stay here, neither here nor there, and he is not able to take a decision when to leave also. Out of force, by the circumstances, he has become a teacher, not out of passion. That is the main problem we are facing. If you ask me, they are not able to go out, and such mediocrity is now growing because of the number of medical colleges are more. The last I heard was 494 medical colleges. If 494 medical colleges to get MCA recognition, they have to have one professor, one associate, one assistant professor, and one senior resident, at least to have one unit. If this is the way we are going, it is very difficult. But at least after becoming a teacher, what we are trying to say, I'm trying to say is that you should be trained to become a better teacher. If not a passionate teacher, you should become a better teacher. That also is not there. Today, a school education requires a B.Ed and M.Ed. I cannot become a teacher in a school. Whereas the day he passes MS or MD, he can become a teacher. Something we have to do about it. This I have spoken vociferously with the Prof.R.Ballal. I'm sure you'll remember what I said 10 years ago. Sir, yesterday he was a student. Today he's become a teacher. The day only thing has happened is he got a degree. So we have to do something for the training of us, become a better surgeon. To train to become a better teacher, you should have at least post-MS, minimum so many years. Then only he has to become something. Otherwise, whatever we are now sitting and talking will not be useful, because only we will be talking among ourselves.
Exactly, Dr. Vijayakumar. Ramesh, 1 minute. Some about nearly 25 years ago, we used to have examiners from Edinburgh and London, places, for Madras University, for MBBS. So one Professor Crickland came as an examiner, but the result was not very good. In fact, I was a very junior assistant there. Then I asked him, sir, why are you like this? This is exactly what he said. See, in UK, the fellowship degree, FRC, is given for you to get trained. They don't become consultant for nearly 8 years. After training 8 years, they become a consultant. But whereas in your country, when I give a pass, tomorrow he'll call himself as a consultant. He'll become a medical teacher also. In fact, the word he said is, an idiot will breed a set of idiots. You have to be careful in India. This is exactly what he said.
Sir, I think another thing that we have to understand is that overnight now we cannot increase number of patients or increase number of cases being done. So I think alternative things where they can develop skills have to be done, like animal labs, at least suturing on animal tissues. They can, there's animals which are slaughtered. They can take the liver and practice suturing the artery, the vein, and things like that. But this should be done on a regular basis. Nowadays, once in a year or once in 2 years, suddenly Ethicon will take 10 students and do. No. Every MS student must be exposed to this on a 3-monthly or 4-monthly basis. He must spend 2 days in a lab where he can improve his skills. And I think that can only come if in every major city, two-tier city, metro, everywhere, if not a single person setting up, a group of medical colleges or teaching hospitals can get together and set up one laboratory where their postgraduates from that neighboring, say, 150, 200 kilometers can go and learn. I think at least here, the techniques can be taught of how to do an intestinal anastomosis, of how to do a vascular anastomosis, so that their hands become used to.
Yeah, Ramesh, I agree with you.
Can I just 1 minute? Ramesh,
hospital in your medical college. There are many medical colleges where Ethicon has set up. Say, Armed Forces Medical College has, Trivandrum Medical Colleges. There are 45 medical colleges where Ethicon has. Only thing is the maintenance by the college is not there. I conduct periodically suturing anastomosis technique courses. You know who comes? Apart from residents, assistant professors from medical colleges come. They simply do not know how to anastomose. They come to learn the technique. And like you
I'm
said,
sorry. Can I interrupt? Can I interrupt? You,
yes,
you
sir.
people take for granted that these people know enough anatomy to do this. My problem is the anatomy knowledge of MS student. You cannot judge their depth of ignorance. I have 11th commandment, thou shalt not ask anatomy questions. Good student, exam going students, the moment you touch anatomy, they're zero. I believe that there should be a examination at the end of first year to check the anatomy level. They don't learn. All of us worked as anatomy. I'm sure Dr.Surendran, many people worked as anatomy demonstrator 1 year to refresh your anatomy before he joined the MS. Today,
You are
basic
absolutely
anatomy
right.
is not known.
Sir, you are absolutely
No,
right.
I'll go one step more.
And I think the main reason, if I look back upon my own career, that I was a very good student of anatomy. I did very well in the examinations, and even in the prize examination, I was in the last 3, but I didn't get the prize. But I had qualified to that level. But I was just mugging up things. I was just mugging up things.
No,
when I came to MS,
listen to me. My granddaughter is in the final MB. When she was first MB, I asked anatomy question. Then she says, my teacher said these things are not necessary. She's a very good student. She's a topper.
I no. When I went to first year MS, I suddenly realized that the anatomy I had studied is of no use to me as a surgeon because they did not teach us towards how applied anatomy. So in England, surgeons teach anatomy, which is, I think, the right.
I was lucky because 2 of our teachers were surgeons. Professor
So that would be very ideal if they are surgeons.
Can I speak?
Baskaran, question from the floor, Baskaran.
Like many of the panelists have said, I interviewed a person who finished his MS recently from a medical college in Tamil Nadu. He had absolutely zilch knowledge. He had not done a single procedure independently, not even a hernia. So I was the other day.
And then you should become a teacher, medical teacher.
I don't know. This is what I use.
Very practical session.
Yes, but this is happening in Tamil Nadu from Tamil Nadu medical government colleges. Professor Surendran has been in Tamil Nadu government service for such a long time. Sir, what is your reason for this?
No, well, let me tell you. Before that, I just wanted to tell you that recently I've read in Pakistan, I believe before they register your degree, MS or MCH, you are supposed to undergone at least 3 skill courses like this hands-on and produce a certificate. No such thing is here. Once you get a degree, you become a consultant, you become a teacher, you know, your skill is not assessed. I suppose that is mandatory. You know, you should assess the skill part of it. That's number 1. And about, you say why the Tamil Nadu medical colleges are not teaching. I'm sorry to say that it is not to offend any of our colleagues here, but still, I tell you one, as Ramesh said, the number of students have increased. So disproportionate to the number of, you know, the infrastructure what they have in the medical colleges. It is just not possible to train everybody. You just imagine 28 MCH student in a department. How will they train? They can't even enter into the theater 28 people. So that is number 1. It's a mismatch between the availability of the infrastructure and then the selection of students. Number 2, teachers. I really doubt that whether they are really interested in teaching. That's number 1. And of course, the super specialty, that's a different issue. But in the general surgery, that is basic. In a general surgery, they are made to work from morning 9 to 1. So the timing is supposed to be from morning 8 to 2. They work from 9 to 1. About 3 or 4 hours. What major surgery you can do in a department? Okay. So in fact, those days I requested the minister at that time, please extend the time. Let us work till about 4 o'clock or 5 o'clock. But there is a lot of opposition and they dropped. And in 3-4 hours. And then I strongly believe every government medical colleges in Tamil Nadu, they have a room for the civil surgeons, the teachers to relax and for the assistant professor to relax. You see morning 8 o'clock, 9 o'clock, 10 o'clock, 11 o'clock, the room will be crowded. Who will do the work in the ward? Only the postgraduates and maybe the young surgeon who wanted to have more cutting chances. They are not being properly. I think there must be a rule that those rooms should be open only after 2 o'clock or 3 o'clock for them to go and relax. Most of them, it's something like I can't use the word, but something like a club. You know, they play cards, they watch TV, and they read newspapers and magazines. I mean, that should not be there in any medical college for that matter, because it's teaching is a very serious affair. Every teacher should understand he has got a great responsibility. I mean, that we are not made to understand. That's the problem. That's because of the selection. That is because of the promotion thing. Now, I had been fortunately, and I was there in some of the selection committees, the faculty selection committee as a chairman, both in All India Institute and JIPMER. I had seen the number of, the students they come. They are so good, in fact. But unfortunately, when nearly about 600 plus faculty were selected in JIPMER, you know how many applicants from Tamil Nadu? There are hardly 18 applicants from Tamil Nadu. There are 700 plus. There are plenty of, doctors applied. Basically because practice. Though the income, what they get, the salary is much higher when compared to Tamil Nadu, but because of the lack of practice, they are not supposed to practice. There is not many people who applied. And not only that, even the 18 people who applied, they are all substandard. We could select only 3 of them. So this is the standard. This is the standard. I'm sorry to say that Tamil Nadu used to be a mecca of medicine, but slowly we lost the name. It's basically because of so many factors. Is it politics? Is it bureaucracy that matters? Or is it doctors? And I suppose we have to squarely blame the doctors, administrators.
Thank you, sir.
It's also true for the rest of the country. It's not only Tamil Nadu. All over the country, I think problems are almost identical. Dr. Vijayakumar would agree with me that these problems occur in most parts of the country, not necessarily restricted to Tamil Nadu only.
Sir, only one point I would like to tell Dr. Baskar here, as a person who is moderating. Can you not look at, we know the problems, we have discussed enough problems. Can you not look at some solutions at least?
Solutions, exactly.
At our level, I don't know whether everything can be done at our level, but what can be done at our level, at least some suggestions, some recommendations.
One, I would straight away agree with Dr. Surendran, train the trainers. I think the medical education departments in certain colleges are really good, but in many colleges, just for Nam Ke Vaste. MCI wants a medical education department, they keep it open. I think JIPMER and Dr. Ananthakrishnan would know that. JIPMER and Chandigarh were the 2, PGI Chandigarh. And we were, of course, unfortunately, by the time my turn came, Punjab was going through an insurgency, I couldn't go. Otherwise, there are no other. So I still remember the day I passed, I wondered, as people have been saying so far, I'm a surgeon, true, but I'm not a teacher. We learned at the expense of medical students. Let us accept it. We learned at the expense of medical students. But today, in certain colleges, a very good medical education department with all the skills. I think Dr. Ananthakrishnan is the right person talking about it. The skills that are needed are given in good medical education departments. But fortunately, that's not universal. Many private colleges, just for MCA's sake, they have a department, right? Dr. Ananthakrishna's comment, please.
Yes, sir. So before I ask Professor Ananthakrishnan, we all know, as Professor Surendran has said, there is lack of interest on the part of the faculty. When you lack of interest on the part of the faculty, how are you going to train? You can take the horse to water. You can't force the horse to drink. How do we solve this conundrum? You have people who are not interested.
Baskar, a lot of discussion was there over several decades that the Director of Medical Services should be separate from Director of Medical Education. But I don't know why it is not done. You have to select teachers, medical teachers separately. You cannot select like selecting for service. So the medical service should be different. So they have to be strict, and the norm should be different. Their working time should be different. Maybe their salary should be different. Should we allow them to practice or not? That's a different.
Surendran, I think some of the states, it is separate. In Tamil Nadu, unfortunately, it is not there. So what happens is that there will be a teacher in the medical college, and one of these in-service candidates who is 45, who has done service for 20 years, will come to do MS. Then he will finish MS, then he will go and join as assistant professors, and 4 years later, once he has finished the mandatory requirement, he will come as a professor on top of the fellow who taught him.
That's exactly
which I think is ridiculous.
That's
Which
exactly
is
what,
ridiculous. So this is
at
but
least,
I think it's only in Tamil Nadu. I think most
True,
of the
sir.
other states, the two are separated.
no, let me tell you what has happened.
Sir, in Karnataka it is separate, sir. DME is separate, DHS is separate, and as you said, the scale of it is also separate, sir. Different. It is more
Unfortunately,
for the teachers.
that's true, sir. Unfortunately, it is not so in Tamil Nadu. You know what happened? One person who was finished DGO, and she was working in a gynecology department for 20 years. She wanted to apply for a MD. She couldn't get, so she has taken a MD general surgery. Just because of her seniority, after 2 years of MS, she was posted as a professor of surgery. And because of her seniority, she became head of the department. And you see
How
that.
can it become, sir? The
Well,
criteria
it's a Tamil Nadu thing.
No, so
Tamil
many
Nadu rule.
assistant professors, so many years you let even
No. Those days, it is not so. Say about nearly 15 years ago, I was talking.
Okay, sir.
Once you become a teaching experience, you become a reader. Reader means professor. Just because the person is very senior in a civil medical list, you become a head of the department of surgery. I think these sort of things did not happen. It's ridiculous. Somebody has to take it to the government.
Yeah,
The government is not listening.
Sir, once again, Dr. T.G. Balchandra wants to make a point.
Oh, yes, please. Go
Dr.
ahead.
T.G., please come.
Brother of Dr. KGB.
Yeah, please switch on your mic. It is in mute. Dr. Balchandra.
1 minute. I'll switch on now.
Yes, please come.
Yeah, actually, a very excellent disposition by all the eminent faculty and teachers, and they talked endlessly about the what should be a quality of a good surgeon in India. That was the topic, you know.
Yes.
So we have covered skills of the surgeons, commitment of the surgeons, quality, and so many things we have discussed actually. But I think a training of a surgeon should not only be teaching his skills, knowledge, and a good kind of doctor, but also you should be trained in research. See, we are discussing so many things. How many institutions in India are doing research and publishing papers? Very few institutions like JIPMER, AIMS, PGI, SGPGI. And I remember when I was in Stanley with the Prof.Surendran, we made a kind of it's a must, do or die, that's all. A program that you have to publish 2 papers, otherwise you will not be allowed to enter into MCH program. So that kind of goal we have set in, and that proved worthwhile. So what we have to talk is, it is the era of an academic surgeon or a surgical scientist should be there. You take, for example, in the world, the top 10 countries which produces maximum number of medical publications. The one is USA. Where is China has come now second? Where is India? India is not all seen now. In 1993, when one Chinese surgeon came to India, Dr. Professor Wang, to attend one bed sharing conference at Vijaya Hospital, he was surprised to see our doctors are having a car and we are having a bungalow. The same China, where has it gone now? Why is it that we are not emphasizing our students to be a part of medical research? Where are we? Look at the other institutions, John Hopkins, this, that, so many names have come. So we have to inculcate and put a proper research program as a part of to produce a good quality surgeon. I want.
The point is well taken, but unfortunately,
Balachandar,
Yes.
can I answer that question?
we are you can't.
But since he brought up this question of
want a basic academic, theoretical, and hand-on skill to get into research. That means they'll be only doing research. From what I understand, if you are going to have 18 people instead of 3, then you'll have to give 15 people some work, which will be only research oriented. But we don't have that kind of thing. We don't have that
no. Dr. Baskaran, you see, the research that you can do while working as a surgeon cum teacher is actually very limited unless you can do research full time. In the US, for example, Anybody doing a postgraduate course, after 3 years, does a year or two of full-time research. They don't come to the wards, they don't see patients, they're just doing research in the lab for 1 to 2 years. And some of them do wonderful research. The professors just guide them, so they don't actually sit and do the research. There are students doing it. But we don't, that's what I'm saying. You want to train them for 3 years and produce full-fledged teachers and masters of surgery. It is not possible. You require 6 years, of which 1 year may be expended in full-time research.
Correct.
But then every hospital has to set up research labs, spend that much money on research, which is not really.
I think it is basically because of the lack of infrastructure.
I want to make one point. We are not only aiming at people who are just coming out of the medical college. Like everybody said, you learn from senior people. If a senior person is not doing it correctly, then there is going to be a problem because the juniors learn the wrong thing. I want a message to be conveyed by all the panelists. I'll give you an example. Supposing a surgeon does a semi-emergency laparotomy for a large gut obstruction, and he finds that there is a metastatic CS stomach and a separate nodule in the colon causing colonic obstruction. So I would think, under the circumstances, all you need is either a bypass or a simple resection of that colon. Supposing this patient ends up having colonic resection, subtotal gastrectomy, distal pancreatectomy, and splenectomy, I really can't understand how do we justify. Dr. Vijayakumar.
This is called as left upper abdominal evisceration.
No, if you can do an R0 at least, I can accept. It is a metastatic disease. So, no, I want you to make a point that just because you can do a procedure,
correct,
it can't become an indication to do a procedure, because that is what everybody is going to learn. So I want
the capability of an individual or an institution cannot become an indication.
No.
For anything.
Let me put it still better. Professor Srinivasan, my teacher, used to say, a feasibility of an operation is not an indication for the operation.
Correct.
Just because you can do something doesn't mean you have to do it. I think that's what Dr.
You see, this can only become better if we develop a culture where postgraduate students are not afraid to ask their seniors, why are you doing this? See, unless you give them that freedom, and I try to give it to my postgraduates. So, you know, they are still hesitant, but they will ask, sir, why can't, should we do this? They will ask. So, you know, you get a hint and then you think back, am I doing right or am I not doing right? And then you, either you justify and do it or you say, okay, we'll abandon it. You know, you agree with them. So I think that one of the things that can improve the teachers is if they can listen to their juniors and understand that even young people can make wise comments. We tend to be very autocratic in this country. We say, what I say everybody has to do. No, you have to allow them to this thing. Then once there's a little democratic discussion, this sort of thing will not happen. But then this doesn't happen very often, Baskaran. I don't think that it is a very common scenario. A majority of us would say,
it could be a smaller one. You do an appendicectomy where there is no appendicitis. You do cholecystectomy where it is not indicated. You may do a right hemicolectomy for appendicitis. You see, if somebody comes to you for appendicitis, the treatment protocol is do nothing or do an appendicitis. Very, very rarely you do a right hemicolectomy. If you do right hemicolectomy very frequently, appendicitis in all other cases, that means there is something wrong in the.
Obviously, say such a person. I'm telling you, in an institution which has got democratic principles, where there is there is a morbidity mortality meeting where people question this, automatically people will karte. But when you don't have any of these meetings, then he will do what he wants.
Bro, and how do we change the teachers? See, I was fortunate.
This is exactly what we call as we need to have an ethicality and morality. Have this, you will not do it.
See, professional honesty is one thing. Dr. Bhaskar, it is what you are trying to say is called professional honesty. This I touched upon. Professional comes only when there is.
How do you ensure this happens in all medical colleges or DNB centers?
You cannot, because
whether it's a medical
it will
college
be-
or otherwise, there should be a system to control it. Checks and counter checks have to be placed in place. If you do not do that, and you want only individuals to do that, that's why one individual is called as a good surgeon or a good teacher, but not the whole system is not producing it. You must have checks and
See,
counter checks.
what happens is that in the United States, the moment the patient comes to think that something wrong, he immediately will file a case. So because of that, they are very careful. In England and Germany and all, it's all a government system. The system is looking very closely because they are spending the
Correct.
money. So they are monitoring it. So somebody has to see, all human beings across the globe are the same. If they didn't have checks and balances, many of them will do unethical things more than us.
Correct.
What we need is some checks and balances system, which unfortunately we as doctors have always resisted. In moment the government wants to bring a check and balance, IMA will go on strike, everybody will go on strike. Yes, if they want to put you down, it's okay. But when they want a reasonable check and balance, I think we should be ready to accept that.
No, I
Okay,
think
excellent.
Ramesh,
There's a question from a
in a culture,
Dr.
we
Baskaran.
always
There's a
try to be
question from a
protective.
student. He says the PGs are scared of the teachers. It's a very unfortunate question. Are PGs scared of teachers? I don't think so.
It is, sir.
Is
See,
it?
see,
They are.
how many of you know Dr. Nandi? Dr. Nandi is a terror to
No, no.
see.
My friends have loved me throughout my life.
To residents to question him. Any decision he does, he says, criticize. Dr. Radha could criticize, I could criticize. If you can justify, he will change his stand. A man of that stature gave us the liberty, so we became independent thinking. Everything was questioned.
Bhaskar, I remember Professor Nandi told me once, you call me an idiot, but you better tell me why did you call me an idiot? That's the thing. When he went to a sabbatical, is exactly what he said.
Yeah.
And so, see, there is always a checks and balances in even Tamil Nadu. But we have a protectionism, like, we say that, oh, we should not let down our colleague. We should not let down so-and-so. So always there are people to protect. And then whatever action you take, that gets nullified. We do have checks and balances. We do have audit me, but they are all bypassed.
So we should have a system of good culture in each department.
Exactly.
Culture will bring in a beautiful set of residents at all levels.
Yes.
From lowest to the highest. So or it should come from the top. Or the lowest or little weak to suggest that. I remember as an undergraduate, as a postgraduate, Professor Ramesh, many of you will know in Bangalore. He was my teacher. I remember those days when he there was an article in Journal of Surgery. It is not necessary to put fasting. So I went and told him, here is fasting. BJ's article says it's not necessary. He said, show me. I showed him. He said, okay, from tomorrow don't put. I'm doing fasting for an appendectomy from those days. I really do not know how many people do not put fasting in open appendectomy now. I was fortunate to have a teacher like that. So how do we get teachers in all places?
Again and again, Dr. Baskar, we are all talking about anecdotal cases of good people, better people, best people. What I am trying to say is kindly make it implementable by bringing a system in place. The system should take care of that checks and counter checks. Then this will not happen. Whereas, as pointed out by people, Dr. Arthanari, that NHS, etc.
Dr. Vijayakumar, who has a voice in MCA, who has a voice in government, who has a voice in university and bodies. Professor Ananthakrishnan.
That's the problem. We don't. See, nobody has.
Vijayakumar has.
No.
Deans are all here.
See, to bring one tumor board in my university, I took 2 years. To bring a tumor board in university, make everybody bring and talk in front of the people. Not even I was trying to interfere, but they are doing. This is the problem. We have been brought up that way. Somewhere we'll have to bring in a system, and the system has to start from local hospitals itself. Why only MCA should come into the picture? We should start the system.
MCA can make it mandatory.
No.
Dr. Ananthakrishnan. Yes,
for
sir.
everything, if you no, I have one point here. For everything, we need not wait for top down only. We can do it at our level.
Okay, we can do both.
But
Down
certain
up.
things we may not be able to do, like a promotion in Tamil Nadu. It is not based on, you have an AIMS and you have JIPMER. There are some selection committee where, a lot of people, they come and they think that they assess whether the so-and-so is eligible for a promotion. But in Tamil Nadu, it is not so. The decision is taken only by your age. You join, you become senior, you automatically get promoted. So only now they said, no, you have to publish 2 papers to get a promotion. Even that too, it not necessarily to be a standard paper, a peer-reviewed papers. So, I mean, you have to tighten all those things. Selection has to be good. The people who really interested in teaching should come into the medical colleges, and the promotion should be based on something else. Not only, not your, it has to be based, broad-based, like your skill and your ethicality, your morality, your leadership quality. All these things should come into consideration when you are promoted. Only then the system will improve. Otherwise, there is no point in we discussing anything.
Correct.
Is it possible that you keep these people on probation for 1 year? At the end of 1 year, can the medical say, you're not going to be a teacher, better leave and go? Can we?
Sir, I am trying to introduce that, sir. I have done it, sir.
Excellent. Okay, Professor Ananthakrishnan, sir.
That's
Would
true.
you like to summarize what are the positive things that can be brought in, or at least some we can talk about?
Thank you, Dr. Baskaran. You see, there is a proverb in English which says, if you look around you, you'll find a lot of things that you don't like. And you can go on endlessly criticizing those things. But a more worthwhile way of progressing is to identify what you cannot change and leave it for the time being. Identify what you can change and focus your energy on that. We have spent a lot of time last 1.5 hours pointing out to some of the deficiencies in the system, which everybody knows. And we all also know that we cannot do much about those areas. So I'm going to focus myself only on what we can do in our own little environment, which is the college that we work. We cannot control the number of admission process. We cannot control the number of postgraduates who enter the department. We don't control their level of motivation or why they have come to surgery and all that. So we have to work with what we have. The first thing is we should have sufficient number of teachers. Most of the universities, and Dr. Vijayakumar will perhaps agree with me, I also belong to the same system that he works in. We do not have enough number of teachers when regulatory processes are not involved or we are not due for regulatory inspection. We need to have round the year sufficient number of teachers as per established norms, 1:3 or whatever norms that are established, at least that much we must have. We must ensure that all those who teach are taught how to teach, which we don't do. The MCI has a course called the basic course, and they have what's called the advanced course. And it's just for filling up and saying that we have done something. Neither of them serve any useful purpose, because we have to change attitudes in order to make an average teacher a good teacher, not by just giving extra knowledge. You have to train teachers to teach. You have to focus on soft skills, which we don't do, because I was watching for a long time, we're all focusing on the operative skills and the perioperative skills. We're not focusing on soft skills, and as I said before, there are methods of assessing these called soft skills and giving inputs for improving the soft skills. After a long strike in the year 1976, it was when I was in All India Institute, we had an 100-day strike, after which the residency system came. And the residency system does not exist in Tamil Nadu. We work like those who have office goers. The residents come at 9 o'clock and they leave at 4 o'clock. There is no continuity of management. We have to insist, and that is within our right. Nobody can stop us doing that. We have to ensure that they provide 24-hour care, which will make them learn a lot of things outside the operating room. We have to make the desired outcome known to the residents on the day of joining or within a week of joining. And that I told you, we are doing it. I'm not talking about it. We are doing it in our place for the last 5 years. We have a list of entrustable professional activities for all the postgraduate departments. There are 20 odd of them, which we give it to the students on day one with established milestones and what is expected of them at the end of 1 year, 2 year, or before they appear in the final examination. How do we ensure that they do that? We have a e-portfolio, which is nowadays free because you don't pay for the cloud space. I mean, it's a very small amount that we pay for the cloud space to ensure that this is happening. And we allot 1:1 mentor for the students to make a record of all that they have done during the day, including the cases they have seen, the procedures they have assisted, the procedures they have performed in the ward, and the teaching learning activities they have attended, what they have learned, what they have not learned, why they have not learned, and so on and so forth. And we ensure that the teachers give feedback on at least, if not daily basis, every couple of days, so that we give additional inputs and make sure that we bring them around to the right path. We have to provide corrective inputs, and we have continuous monitoring, which can be done. We don't require a regulatory agency to come and tell us that we have to do continuous monitoring, because in a profession in surgery, it's dangerous to release into circulation untrained people or half-trained people. And where we make an honest assessment and decide that we don't really have the facilities to train in certain aspects, we should not hesitate to send them on rotation to places where such facilities can be provided on a short-term basis. Many of the institutes are very hesitant to send their students outside for reasons best known to them. And we have done that. It does not always work well in the first year because there's a lot of resistance. But gradually people come around when they understand that it is meant for the betterment of students. Initially students resist, then faculty resist. And if we give some weightage to all these activities of the faculty instead of just blindly promoting them as per MCI norms on writing 2 papers, they are much more likely to do these things in an active and an interested manner. And I'm not talking theory, but I'm talking things that have been done and which we have passed to some of the other institutes also. So instead of just constantly blaming the system and what is the cause of the ills, there's a lot of things that can be done within the institute which can change it. It may not make it perfect, like Dr.Ballal said. But if perfection is the goal, excellence is acceptable. And therefore, we can make a change and we produce better quality of postgraduates. And I think we have to focus on things that we can do, because it's high time that we stop criticizing the system and started pointing fingers at ourselves and looking at where we have failed as teachers. And you'll find that answers most of the questions. Thank you.
Can I add a point, please? Can I add a point? If engineering colleges and private industries can join together, why is it that the private corporate hospitals and medical hospitals are not joined? Because the top quality work is being done in many of the corporate hospitals. Whereas, with due apologies to the government colleges, infrastructure may not be ideal. So is it, I tried this in Bangalore, of course, when Dr. Shetty was the Vice Chancellor of Rajiv Gandhi University. So I wanted it to be a pilot project, but it didn't work out. Because see, people working in the private sector, how many hands-on experience, whereas they go to a government hospital every night, there'll be one perforation, one appendix, they get enough chances. These people come to the corporate setup, they can see some sophisticated instrumentation, sophisticated surgery. It's a win-win situation, but why is it not happening?
Sir, I will tell you that why it doesn't. I won't blame only the institutions.
Is it
I
ego?
used to take classes for postgraduates. So for my postgraduates, I used to get a group of postgraduates, first 1 or 2 were friends of these fellows in the government hospitals started to come. Then every week we started getting 7, 10 postgraduates from government hospital who started coming to these. And with the larger group, we could have a good discussion, and we were able to clear a lot of their doubts. Then one day, 2 of them came to my room and said, "Sir, from this week we will not be coming." I said, "Okay, why, your exams or something?" He said, "No, our professor called us and said, I hear you're going for classes to the private hospital there by this. If I ever again hear about this, you will never pass the MS exam. I will see to that." So it was stopped. So there's no need. Between our own department, there is ego clash. So it is a very difficult thing to bring.
Yeah, thank you. I think we'll have to wind up shortly. Yes, Professor Surendran has a point. Yes, sir.
No, Ramesh, what Ramesh is correct, but if it comes from the higher up government, says that you can attend classes and the corporate hospitals consultant can take class or they can be involved in teaching, and I suppose that's an added one because as rightly said, the facilities available in the corporate hospitals you cannot use in a government institution, so it can be done. And to some of the points which Professor Ananthakrishnan said is very well taken. But unless you analyze the future, unless you say what is wrong with the system, and you won't be able to see a solution. And maybe he is good enough, and Vijayakumar is, the vice chancellor, with his capacity, is able to do something within his university. But what I thought, it should be done at a larger scale, like the government should come in, the policy makers should come in. Only then the government institutions can come up. Otherwise, there is no point in we talking. There may be some islands of excellence, but what we are talking now is how to improve overall. So these things, I suppose, it will help. We have to go through what is wrong and how it can be corrected, and maybe we have to give an advice to the policymakers and the bureaucrats. Whether they take it or not, and I don't know.
It's okay.
Professor Surendran, it's never likely to come from higher up, because their priorities are quite different from the priorities
but we have to keep trying,
of
sir,
teachers.
No? But can
and the ratio 1:1500 to 1000 increase so that you flush them out, which is a rather unfortunate way of describing it. As Dr. Vijayakumar said, what happens to things that we flush out. Therefore, you don't expect that government will play an active role, because they have a vested interest in other aspects of policy, which has to cater to re-elections or to catch the public imagination. They are not interested in improving the quality of outgoing postgraduate surgeons.
But
we understand that. It is understood. When motivated people come into governance, maybe it will happen in some future time, but I have no great hopes that will never happen in regulatory levels. The MCI is dead, and MCI is dead, and it's replaced by a commission, which in many ways is much worse than what the MCI was in its worst days. So, and then in between we have the Board of Governors who have their own priorities, and they have listened to the governor or the government, otherwise they'll be changed. So we know all these facts of life, and because we have also been intermittently associated with these regulatory agencies. Therefore, it's good. We are aware when we try to do that on a long-term basis. But if we wait for it to happen, even short-term basis, we won't do anything. So I think we have to focus on what we can do, and then create a wave that changes the government policy.
Thank you, sir. I think it's time for us to wind up. I thank all the panelists. We had an excellent discussion on what qualities a surgeon should have, what are the problems we have in achieving the required goals. And of course, many of us know many of the problems which are there. As Professor Ananthakrishnan has pointed out, I think we'll have to start the change. We'll have to start the change, and change should come either from top or from below. If we think it's not going to come from top, we'll have to do it from our level. Each unit, a unit 3 in one hospital can probably become better than other units, and it will force other units to pull up their socks and start doing it. And the point that the curriculum should be extended to beyond 3 years, which is inadequate at present, is a very tough call to make, because for whatever is the reason, economy mainly, and I think it's a long-term goal. Or like in the north. In north, after 3 years, they all join as senior resident. And during that time is the time they actually learn the surgical skills, management skills, and decision making and everything. They call the shots. They are the people who run the departments. Maybe something like that should come in Tamil Nadu and few other states. I think Dr. Radha has asked me to wind up, and I thank all the panelists for sparing the time and for contributing to this excellent discussion. Thank you very much. And there has been a lot of questions raised by many of the participants, and they've been answered appropriately by all the panelists. And before Radha gives me any other call, I would like to thank all the panelists for their wonderful presentations. And thank you very much. Thanks for sharing your time. Thank you.
Thank you.
Thank you very much.
Thank you very much.
Thank you very
All
much.
the
Pleasure listening to all the
panelists for their valuable time, and thanks Baskaran for putting the whole show together. There's another program in another few minutes, so we had to call this off, and we shall meet again soon. Thank you so much. Thanks everyone.
Thank you. Thank you, Radha.
Thank you.
Thank you, Bharat.
Bye-bye, Dr. Bhaskar. Thank you.
Thank
Thank
you.
you, Zers.
Very much.
Thank you.
Bye.
Nice to see you all. Thank you. Bye-bye. Good
Bye.
night.